Good morning, one and all. My name is Prathima. I'm a research fellow in neurosciences at Mayo Clinic, Rochester, Minnesota. Today, I'm going to present to you one of our projects on trial stimulation and chronic spinal cord stimulation for the restoration of volitional motor control after spinal cord injury. This project was in collaboration between Mayo Clinic, Far Eastern Federal University, and Kazan Federal University, Russia. As we all know, epidural electrical stimulation is an effective treatment procedure for chronic pain and spasticity, but it has also proven its efficacy in reestablishment of functional connectivity in patients with spinal cord injury, and as well as improvement of non-motor functions like bowel and bladder control. But there are multiple factors like position or location of the implant and electric field distribution that determine the effect of electrical stimulation therapy. So, in our study, we use trial stimulation in the subject with motor complete spinal cord injury to evaluate the effect of epidural electrical stimulation before chronic system implantation, and also to determine the position of the electrical implant and electrical field to optimize for the individual needs and to ensure the long-term effect of chronic implantation. Here we have a 40-year-old male with chronic motor complete spinal cord injury with Asia Impairment Scale Grade B, who was implanted with two kinds of electrodes. In the first picture, we can see an implant which has two electrodes with 8 contacts each. This was used for trial stimulation. And in the second picture here, we can see a single implant which has 565 arrangement of the contacts, and this was used for chronic stimulation. This is the timeline of the patient which was involved in this, who was enrolled in the study, and starting from the initial time when he sustained the injury to his back in the mid-thoracic region to the time when he was enrolled for the study. So during his initial injury, the patient had complaints of numbness and weakness in his lower limbs and bowel and bladder dysfunction. He was treated for the same and received physical therapy. But during the course, he also developed an encephalomyelitis for which he received treatment with plasmapheresis and cycles of hormone therapy. Although the patient had positive improvement in his symptoms, eventually the patient's condition got worsened, and his MRI in 2001 showed thoracic intradural intramedullary tumor at T6 spinal level, for which the patient underwent subtotal tumor resection. Later, in 2005, the MRI of the patient showed intramedullary tumor mass enlargement. The patient received physical therapy, conventional physical therapy during this time. And later in 2016, the patient's condition still worsened with increasing spasticity, increasing back pain, and eventually complete paralysis. During this time, the patient's MRI showed intramedullary tumor at the level of T5 T6 spinal level, and the patient underwent tumor microsurgical resection, and later, until the time he was enrolled to the study, the patient underwent conventional physical therapy. This is the MRI of the patient of the thoracic spinal cord in 2016, showing intramedullary spinal cord tumor at the level of T5 and T6. When the patient was enrolled to the study in 2019, he was implanted with two kinds of electrodes. One is for the trial stimulation, which had two electrodes with 8 contacts each and was placed for a period of 1 week. During this 1 week, the patient underwent epidural electrical stimulation facilitated motor training. Later, after 1 week, the patient was implanted with chronic stimulation system, which was also followed by epidural electrical stimulation facilitated motor training. During the period of trial stimulation, the patient showed single joint movements and complex rhythmic movements during training. And during the period of chronic stimulation, the patient was able to have volitional control of selected joint movements and complex rhythmic movements, along with a few non motor functions. These are a few electromyography recordings that were taken during the training sessions. In this particular slide, we can see the muscle responses recorded during trial stimulation. These are the muscle responses recorded at various contact positions in both proximal and distal muscles. The first three muscles are the proximal muscles, and the next three muscles are the distal muscles. The proximal muscles included are rectus femoris, biceps femoris, and vastus lateralis, and the distal muscles are tibialis anterior, gastrocnemius, and soleus. We can see a clear motor activity or motor responses of the muscles during stimulation. Similarly, these are the recordings taken during chronic training with chronic stimulation. As we can see here, when the patient was stimulated, there are the we can see heightened muscle responses compared to the recordings taken when the patient is trained without stimulation. Here are a few videos which were taken during training sessions, during trial stimulation and during chronic stimulation. The first video is taken when the patient was trained with trial stimulation. Here we can clearly see the patient was able to move his right leg single joint movements with trial stimulation. In the second video, this is training for complex rhythmic movements during trial stimulation, where the patient was able to do his complex rhythmic movements of in a step-like manner. In this video, we can see the patient being trained with chronic stimulation, but initially the training was without stimulation, where we can see the leg movement, and when we compare it with stimulation, the patient was able to move the leg more effectively compared to without stimulation. This is the video. In the fourth video, we can see the patient training with chronic stimulation on the other leg, on the left leg, without stimulation. And with stimulation, the patient was able to move his leg more efficiently. From our project of trial and chronic stimulation, we see volitional control of single joint movements and complex rhythmic movements during trial stimulation in a patient who was previously completely paralyzed. And this theory supports discomplete spinal cord injury in this patient. Also, this was true with chronic stimulation as well, with selected volitional control of selected movements. In chronic stimulation, the patient also showed improvement in spasticity of his legs, which was evident through modified Ashworth scale score, which was +1 before trial stimulation and 0 after chronic stimulation. Apart from the motor functions, the patient also showed improvement in non-motor functions like bowel control, with a satisfaction of 10 on 10 with the neurogenic bowel dysfunction scoring system. Therefore, with our study of trial and chronic stimulation, for the first time demonstrated that the trial stimulation can help in the initial assessment of motor complete spinal cord injury subjects to predict the outcome of chronic epidural electrical stimulation in recovery of volitional motor control. Initial trial stimulation may further help to optimize the implantation of the electrodes and to determine optimal lead location and stimulation settings considering the individual difference in patients with spinal cord injury. This approach of trial to chronic stimulation may help to assess the efficacy of the chronic epidural electrical stimulation and would be important in cases when no clear evidence of discomplete spinal cord injury is available or with no or limited rehabilitation prior to implantation. Thank you.